today. Tom Hurst is going to be a new person. We'll get him introduced in a second. So I'm just going to still wait a little bit for a quorum, but I'm glad everybody else seems to be plugged in here so far. Holly Hooks, hello. Good to hear from you. Can you hear us okay? Holly? Well, I don't know. She's probably looking for the unmute button, that kind of thing.
No,
Holly?
I'm here. Sorry, it froze. Hi, Dr. Pepe.
All right, good. Just want to make sure you're on. You can hear us okay, and we can hear you okay. So that kind of thing. And we move real quickly. You don't know when I'm going to hit you. I mean, that's the thing. You got to really pay attention, right? Okay. All right, so it's good. So we got a couple people that are going to have to leave by the top of the hour. Okay, me. No, I'm just kidding, not me. But you know, Mike Kaufman and Sandy Schneider that I know of. Anybody else that I need to know about? Sandy and Mike. Okay. Okay. Otherwise, everybody else is pretty good for the time being. That kind of thing. Okay, I'm planning to have a meeting in a few days. Okay, a few other people are texting me about other things, so sorry about that. Okay, so Mike and Sandy. Okay, good. Okay, let's see who else is on now. Let's see at this point. Let's see, we got a pretty good quorum going on. Okay, so far. So I think I'm going to probably launch into it here in just a second. I got to figure out what tactic I'm going to take. Emily Nichols, what's going on here? I'm going to report you to the FBI for suspicious behavior two weeks in a row, right? So.
I know. Trying to make a trend.
Yeah, it's great. Good to see you then.
Awesome.
Yeah, it's terrific. All righty. So let's see. Let me go ahead and get started with a couple of things here. I'm going to be tracking a lot of stuff today. So I don't know if we'll get through the agenda. As you saw, it looked pretty ambitious. Even I was like going, there's no way we're going to get through this, but we'll see how it goes. Let's see who's in the chat here. Let's see if there's anything I need to know about. Got to hop off. Okay, so Mike, we already know about that. Sandy, know about that. John, good. I'll catch you in a little while. And can only be first half an hour, okay, but no updates from Chris. CME, that's a good one. CME code for today. The CME code today, as you could predict, is 12952. 12952, okay? And again, once again, thanks to Memorial Regional Hospital, who've done great work with us this year, and not only providing this, but you know, all the assistance they've done with the research we've done there as well. Let's see. And then what time are you have to leave, Lakshmi?
In an hour.
Okay, good. All right, I'll try to get you all in. Okay. All right. And then Scott's having some computer issues. All right, good. I just want to sort of have a good organizational trend here today to make sure we get through this efficiently, get through a lot of stuff here. So just as an introduction to some of the folks that are on the phone here. Hey, Amal, how long do you have? An hour?
I have an hour also. Thanks, Paul.
Yeah. Okay, good. All right. So as an introduction, everybody here, this is the gathering of the jurisdictional medical directors of most of the largest cities in the United States and many of their counterparts elsewhere. And we get together. This is recorded. It's put out to not only on our website every week, so you can follow up on it or hear it again, but goes out to many, I don't know if the word is hundreds of thousands, tens of thousands anyways, through EMS World. And so thank you all for being here today. And then AJ, are you prepared to do that presentation on the NEB thing today? Are you there, AJ? Don't know if he's there or not. I see him there, but we'll see. All right, so let's go ahead and start with a couple reports. Let's go run through Mike Kaufman. You guys have been doing really good stuff along the lines of getting like thousands of people vaccinated in a weekend kind of thing, right?
Yep.
Want to tell us real quickly about where you are with that and give us an update on that? So Mike Kaufman is our state medical director from the state of Indiana and is our representative from the National Association of EMS officials. And really great to have you on board and
Thanks,
doing
Paul.
great work in Indiana. And tell us about the Mota Speedway. Okay.
Yeah, thanks, Paul. I appreciate the opportunity to give a quick update. As you know, one of our big Eagles initiatives has been to help with mass vaccination planning. So in that regard, we've been collating information from our third theater group here, working on mass vaccination plans and best practices. And I wanted to share with you today our own experience here in Indiana on mass vaccinating. And I know this is something that Jeff Goodlow is going to be a huge fan of because he's a huge motor racing fan and a big fan of the Indianapolis Motor Speedway. But I can't think of a better place for a drive-through vaccination clinic. Not at certainly not at 200 miles per hour like they do during the Indy 500, but at normal speeds. So this last weekend, we hosted really our largest mass vaccination site to date. I like to call this personally the greatest spectacle in vaccinating, if you can see my screen okay. And this was just a really awesome event that was planned and operated by our county health department, but more importantly, our Indiana Department of Health. It was a 5-day event that was a drive-through clinic at the world's largest, outdoor motor speedway. We did about 4,000 vaccines per day over the course of about 5 days. And if you've ever been to the Indianapolis Motor Speedway, you know that it's a 2.5-mile oval and just really a site in and of itself. So it provided a great venue. As you can see here, we brought cars in off 16th Street, looped them around through both an intake, a registration. We have a central registration system in our state for vaccinating and for signing up for vaccine. We brought and you can see the map here that I'm just running through very, very quickly. It's an aerial view of the Motor Speedway, how we brought them in through lanes, how we staged them, how we screened them. It was really neat to see cars come in through Gasoline Alley. If you're familiar with that, those are the garages where they work on the cars during the entire month of May in preparation for the race. This was our governor, Eric Holcomb, receiving his vaccine as he fell into the age group categories and was eligible to receive the vaccine, was one of the first to get those that day. You can see the iconic timing tower at the Indianapolis Motor Speedway in the background. Cars actually registered and then pulled right into the garage bays where we had multiple bays set up. Again, we were able to put through about 40, I think our busiest day was about 4,200 vaccinations given. They pulled in, got their shot, and then pulled out. They actually got to pull out onto the track itself. And it's interesting when a lot of cars hit that pit row and saw the big timing tower headed down towards turn one, a lot of people hit the accelerator and had to be told to kind of slow things down just a little bit. But again, it was just a wonderful event. We got about 20,000 doses of the Johnson & Johnson vaccine delivered over that 5-day period, and I can't say good enough things about this. So as a resource, I'm happy to share our action event plan with all of you to help better prepare for your own mass vac sites in your areas. And again, the Indianapolis Speedway was a great venue for this here locally. So thanks for the opportunity to tell y'all a little bit more about it.
Good. Hey, and Mike, did you guys use a pit crew approach there? That's I was just curious. Okay.
Yeah, it was a team effort, and I have to say the Indiana National Guard really stepped up and had a bunch of folks there to help. Our EMS crews were there helping to administer vaccine and monitor for reactions in the monitoring area, and it was really just a great joint effort from all of our state agencies.
I
Fantastic.
gotta tell you, I'm stealing this and going over to the Daytona Speedway. I'm stealing your idea, Mike.
I'll send it to you, Ken.
Ken, as you know, and most of you know, that Ken has probably the largest R&D department in our outfit, right? Tell them what the R&D department is, Ken.
I'll be ripped off and duplicating this right away. All right.
Rip off and duplication. That's right. It's great. Well, good for you. All right, let's move on. Let's see, what is the moving on part going to be? Oh, I'd love to see Sandy Schneider. So Dr. Sandra Schneider, introduction. She's the Associate Executive Director of the American College of Emergency Physicians. They're top doc, as I always would say over there. And we're always glad to have you on board. And so what do you have for us today, Sandy? Anything new from the American College of Emergency Physicians or from you?
Yeah, so first off, we're continuing to work with COVID. We've got a new resource I'm going to put into the chat. Hopefully, whoops, that didn't work. I'm going to put into the chat. We're trying to do some surveillance on COVID after vaccine. There's a very, very simple form there to fill out, and also some instructions on how to locate or give your health department a heads up. And there's a lot of interest right now on vaccine breakthrough. So we're not, please let us know on that. The other main issue I wanted to talk about was ketamine. As you know, we had a group that met with the FDA that included Mike Levy, who I think is on this call, David Tan, Brent Myers, Jeff Goodlow, and Ben Hatton, and I probably forgot somebody. We have filed the report with the FDA. They have said that already that they would like to come back probably with some more questions for us. In the meantime, we have heard that there's some legislation in a federal level that is talking about ketamine. I sent that out to a bunch of people on this call to look at. it appears that that's really primarily looking at law enforcement, saying that law enforcement should not administer ketamine. It does not appear to have any restrictions whatsoever for EMS. There is a sentence in it that we need some clarification that also talks about public employees and whether that would be a problem for EMS. So we're getting an interpretation of that. And obviously, if that's going to be a problem, we need to strike that out of that. But again, this is pending legislation. It's not anything that's being voted on actively, etc.
Fantastic.
And then, I'm sorry.
Oh, it's a fantastic. Good.
Okay, perfect. Okay. I always, I just rattle on, you know, I'm from New York, so I just keep going.
Yeah.
And then the ketamine paper is in its final version right now. So I anticipate that the new white paper, shall we say, on excited delirium, which will be totally renamed, will be coming out hopefully within the month. But if we run into some problems with the board, it might take a little bit longer. So that's all the updates I can think about for the moment. So I'm happy to answer any questions as always.
I had a
Cool.
quick question.
Yep, go ahead.
So for the law enforcement ones, you do have paramedics that are embedded with SWAT teams. They are both paramedics and sworn law enforcement. So we have to be a little cautious on that law enforcement line as well.
Got it. Okay. Thank you. That's exactly the feedback I needed.
And Sandy, we also have some paramedics that are law enforcement. For example, the Maryland State Troopers run the helicopter service, for example. And there are other examples of police officers that act as a paramedic role. So we need to be very careful about that.
Yeah.
I think the cleaner language is non-paramedic, right?
I will make sure we, so I saw Ken and Dave. Let me give this legislation to you to look at, you two, and if anybody else wants it, please put it in the chat. I'll send it to you and then you can provide that. That's exactly the feedback I need because there are nuances that I might not be aware of.
If anybody else has anything else, please do send it to Sandy. You know, she's easy, sschneider@acep.org. All right.
I don't know
Excellent.
about me being easy, Paul, but that's okay.
Yeah, right. You've always said that about me, though.
That's a different story.
Yeah.
Sandy, if you need any case vignettes, I have 6 from last night. So feel free to reach out. I'll send them all to you.
Yeah.
Thanks. Thank you.
Vignette, is that something you can eat for like as an appetizer? Is that what it is? That's,
Little snippets for attention.
yeah.
Why did we turn him on? What did we do to get Pepe off?
I got up too early and then went to bed too late. Okay, so I'm just in this, sleepless phase. Hey, okay, good. Thank you so much. Let me move on then to, first of all, I just want to make sure, who's 337? Is that you, Glenn? Area code 337? Just want to make sure.
Happy, that's Chuck Burnell. That's me.
Oh, Chuck. Okay, got it. Thanks, Chuck. Just want to make sure I
Yep.
know who's on the line.
Thank
with
you.
that.
Appreciate you checking.
I guess since we're in Fedland and all that as well, so let's move on to moving up the hill to John, Office of Emergency Medical Service. Any report from NHTSA?
Nothing real earth shattering. Obviously, there's a lot going on with vaccine issues. I am in no way, shape, or form advocating, but just make sure that folks are aware that there has been from a number of EMS agencies, language included in the Senate bill that was passed last weekend addressing reimbursement for treatment in place. The House has provided similar language and is expected to be voted on later this week for information purposes only. I'm sure that folks are aware that the CDC released some guidelines yesterday on post-care or post-interaction of folks who have been completely vaccinated. That's good news and bad news. I mean, we are making some progress. The bad news is I think a lot of folks are going to equate that to now we can get rid of all masks and social distancing and all the other complaints, all the other compliance issues. So just be aware of that. And I think we talked last week on a non-COVID issue, but there is increased monitoring activities going on related to Ebola cases in Africa.
Yeah.
and there will be increased screening for folks coming into the country from selected countries in 6 particular airports: JFK, Newark, Dulles, Atlanta, Midway, and LAX. That's it, Paul.
Yeah, I think, and we talked about that last week on the CDC call. That was like a week ago when we first heard about this. So, okay. Thanks for reminding me about that one. That's a good one. So I think that's all there is to that in particular. Hey, so let's, since you brought up the issue about the, if you've been vaccinated, what now kind of thing, guidance that came out that we had talked about last week, and now it's coming to fruition. We have Holly Hooks is on with us from the CDC, and this is basically her just going over a couple of things. And for those who didn't catch it, I think we sent it out to everybody, but in case you didn't, I want to go ahead and make sure that you get to hear a little bit what's going on, and we can see if there's any questions that you have about it. Holly, you want to take over for us? Okay. So,
Sure. Yeah. So thanks, Dr. Pepe.
yeah, I just wanted to let you know, Holly's been great. She organizes some meetings with us, partnership meetings on different ends, but with both emergency medicine and with, well, many other organizations too, but with us specifically. And we're really great that. So I asked her to come in, her or Dr. Visser. Dr. Visser couldn't make it this week, so Holly said, I'll do it. So there you go. Hit it, Holly. Okay.
Yeah, thanks for having me. It's great working with you guys. So like Dr. Pepe said, I'll just give you a brief overview. So it's important to note that the guidance is for those who've been fully vaccinated. So what does it mean to be fully vaccinated? People are considered fully vaccinated either 2 weeks after their second dose in a 2-dose series like Pfizer or Moderna, or 2 weeks after a single dose like Johnson & Johnson's Janssen vaccine. If it has been less than 2 weeks since your shot, or you still need to get your second dose, then you are not fully protected. So keep taking all preventive steps until you're fully vaccinated. So the question we've all been asking, is there any time that a fully vaccinated person doesn't have to wear a mask or social distance? So you can gather indoors with fully vaccinated people without wearing a mask, and you can gather indoors with unvaccinated people from one other household. So for example, visiting with relatives who all live together. You can gather with them without masks unless any of those people or anyone they live with has an increased risk for severe illness from COVID. So what if you're fully vaccinated but exposed to someone with COVID-19? If you've been around someone with COVID, if you've been around someone who has COVID, you do not need to stay away from others or get tested unless you have symptoms. However, if you live in a group setting like a correctional or detention facility or group home and are around someone who has COVID-19, you should still stay away from others for 14 days and get tested even if you don't have symptoms. So I just want to leave you with a reminder of what hasn't changed, because I think that's important to highlight too. And that's that you should still take steps to protect yourself and others in many situations. So do things like wearing a mask, staying 6 feet apart, avoiding crowds and poorly ventilated spaces, and take the precautions when you're in public, or if you're gathering with unvaccinated people from more than one household, or visiting with an unvaccinated person who's at increased risk for severe illness or death from COVID-19, or who lives with a person at increased risk. You should still avoid medium or large size gatherings. You should still delay domestic and international travel. And if you do travel, you'll need to follow CDC requirements and recommendations. You should still watch out for symptoms of COVID-19, especially if you've been around for someone who's sick. So if you do have symptoms and you've been vaccinated, you should get tested and stay home and away from others. And then also always follow the guidance at your workplace. So you can find all of this on our website, which I can link in the chat. So thanks for your time, and thanks, Dr. Pepe, for having me today.
All right, no, it's great to have you on board and all that. And then we're going to, of course, react to it, particularly with respect to like the issue with the J&J, et cetera. But we'll see, because it's based on, best guess is in terms of trying to push this out. So I want to have some of our ID people on. I think, unfortunately, Rob Holman couldn't make it today. He's our Washington, D.C. medical director and an ID guy. We do have John Jew on, but one person I do want to introduce who's joined us today. I've been very fortunate to get to know her. She must have been born very young, because she's been at this for quite a while, and worked with us at Health and Human Services. And Andy, you may have run across her at one time enough, but she's Dr. Eileen Marty. Eileen's been on a lot of you've seen her probably a lot on a lot of the network discussions over the last 8 or 9 months, et cetera, and been very articulate. So it's great. And we're really lucky to have her down here at Florida International University, and where she's in the infectious disease practice. Any comments you want to make about it, Professor? I should say Professor Barti, right? So go ahead, Eileen.
It's a pleasure to meet all of you. I had such a lovely chat with Paul, and he mentioned what a terrific team you are. So I'm just honored to be part of the team. I do have my own thoughts on these various vaccines and the new recommendation, but I prefer today to hear what you all have to say.
Okay, got it. That's fine. We may come back to you because we probably are in agreement in some respects, and we're pretty good about saying things. And of course, I'm really jealous of your background. Okay, so and Dr. Marty lives down in Miami Beach, so lucky her. So that's good. But she's a dedicated person who works around the clock. Unfortunately, she put in an application for 28th and 29th hour, but it has not come through yet, from what I understand. Right, so in a 24-hour period. Okay, so let's move on. John Jew, he's not only our medical director from Portland, but also infectious disease expert as well. John, any reaction to the news, or is it like we already been talking about this anyways for several weeks, I think? John,
yeah, thank you, Paul. Yeah, can you hear me?
Yeah,
sorry.
Sure. Yeah.
Can you hear me now?
I can hear you now.
All right.
I could hear you before.
I got a little problem with my yeah, sorry. Yeah, so I really like the new guidance, but from a science point of view, my colleagues, including infectious disease, would like to know the answer to the following questions. And this is really directed to Holly, and you may not have that answer. Is we currently do not know with the current strain as well as the new variants how effective post-vaccination are, if they are effective. And I believe CDC has some probably some data that we're not seeing in the public arena. That's number one. So the questions I have from my fire and EMS colleagues are, there's a lot of quote unquote unknown answers. We really like CDC's guidance, but the science behind the guidance is not readily available. The second question to Holly and CDC is, as well as Dr. Marty, is where is the guidance if the strains are different, like the B117 or the B1351? Is that guidance applicable to those strains? And we're starting to see those strains more in our U.S. Third is really operational. Do you consider fire and EMS houses residents, or do you consider them public places as well? And so I'm considering them quote unquote quasi-public residents. And so our fire colleagues are probably, especially if they're taking their mask off, wanting to take their mask off. Back to you, Paul.
Okay, got it. So Holly, you're not in a position to answer, but there may be something. We don't have a call today, right? We're going to put it off till next Tuesday, correct?
That's correct. And actually, we're really glad for all the questions that you guys have. And yeah, Dr. Pepe's right. I'm not in a position to be able to answer them. But if you keep putting them in the chat or ask them here or tell Dr. Pepe, we can definitely work on addressing them in our next call next week.
Right, right. And, or maybe if he gets it so we can get on the, maybe Sue or someone else could get on, with us next week and have some answers, and that would be really good. So obviously it's just all coming out, and we're just, there's always going to be some nuances. So as we move along, there may be other questions that will come up as this thing goes on, either in the chat or during the week, and as things go along, and we go, okay, how does this apply? Can we do this? Can I do this? Or who is it that we're? That one thing I would bring up right away is that we have a lot of experience so far with the mRNA viruses, but I'm not sure if we have had enough with the J&J to sort of have that level of comfort, and we'll see. And again, it may be what we talked about before, different patient populations that may have been studied or different variants that were exposed at that time, but we'll see. One thing I want to talk about, anybody else have any questions about that or reactions that you want to talk about?
I would like to comment on it.
Sure, Riley. Yeah, go ahead. And then we'll pop over to somebody else in a second. They just sort of wanted to say something, but go ahead.
Oh, sure. No, it's just that, first of all, his question was brilliant. It's a really important question as to the what these different variants, how they impact on the various different vaccines, the 3 vaccines that we have available right now. And you're absolutely right. We need more data on the J&J regarding those things, but we have a hint from what happened in South Africa with the J&J, right? So that there's clearly a problem with the vaccine there, and therefore it has to be looked at more carefully. But there is a pre-pub work that's been done with the Brazil variant, and apparently the vaccines are still very, very effective against the Brazil variant, which is curious since both the Brazil and the South Africa have that E484K change that is one of the key reasons why some of these viruses have become escape mutants.
Yeah.
So the bottom line answer to what he's asking is it really depends on which variant you're talking about.
Yeah.
And what you mean by efficacy. Are you talking about no symptoms whatsoever, or are you talking about severe symptoms and hospitalizations? And that's an important difference between these various vaccines. And moreover, I think it's really important that everybody here recognize the fact that the J&J vaccine right now is under trial as a 2-dose vaccine, which is to get it. And the other important point about that issue is the fact that the J&J vaccine is half of Sputnik 5. It is literally half of the vaccine that's being used in Russia.
Okay, thanks. That's great information. Well, that sort of puts me over to talk about 2 things. One is that, you know, for example, Scott Gilmore, you were commenting the other day about Mike. Mike was going to try to get on, but he's out at the White House right now. Mike Osterhope, that said we're really in the eye of the storm, and that we're going to get a lot more of the B117 coming along, and we may have some spikes here. Was there anything else you wanted to add to that, Scott, before I switch over to Fiona and the NHS?
Oh, it was just very interesting, the comments that he made. And if you actually go to the center where he is the director, he does a weekly podcast, and you can look at the transcript, and it's very informative.
Okay, good. And everybody knows them. So let's since we're talking about that, if that's going to be our primary thing here in a few weeks, Fiona, you guys have been obviously had a lot of it over there in the UK. And then, by the way, I'm going to have you introduce Tom in a second, okay, if you don't mind, Fiona. But first, let's go ahead and you know, pitch to you and say what's your experience with the vaccine and how it's been covering your variant there.
Good afternoon, Paul. Good afternoon, everybody. Yeah, we are continuing to vaccinate down the tiers. We've vaccinated over 20 million of the population now and are starting to administer the 2nd dose of the vaccine. We're the next stage of the lockdown, or releasing the lockdown. We saw children going back to school on Monday of this week, and there's a sort of staged release of the lockdown over the next couple of months. But the message here still is very much maintaining space, wearing masks, and and basically sticking to all the precautions that we have been so far. In terms of reactions to the vaccine, we have seen maybe 8 to 9% of people getting the Oxford AstraZeneca having 24, 48 hours off work with fevers, aches and pains, headache. So we've factored that into our vaccination program so that we try and ensure that it doesn't have a big impact on operational resourcing.
Yeah. Okay, good. Any other comments from your neck of the woods? And she's got Southeast Ambulance over there. And so how about, anything else, or do you want to introduce Tom to tell us about him? Okay.
So I'm very happy to introduce Tom. So Tom Hurst is a consultant anaesthetist at King's College Hospital, which is one of the 4 major trauma centres in London. He's done a lot of work there, including work on ECMO, but he's also the clinical director of London's Air Ambulance, and he's been doing that role for probably 3, maybe 4 years now, although he's worked with London HEMS for quite a long time. A great guy, taught me huge amounts. So I'm delighted to see you on the call, Tom.
Okay, great. Tom, anything? Well, first of all, why don't you come on, and then any perspectives from you before we move on to other topics?
Thank you. Thank you very much for the introduction, Fiona, and thank you, Paul, for the invitation to be here. It's great to meet people. My role is very different to many of yours. Our service is a small physician paramedic staffed service that attends only major trauma patients within the Greater London area. So a very different medical director type role. Yeah, nice to be here and to hear your perspectives. Thank you.
Okay, good. Well, thanks very much for, and thanks for putting up with me earlier this morning too, as I was riding along in the breeze, okay, so to speak. All right, so thanks for being here. Hey, Mick Malloy, are you there today up in, from Dublin? Are you there?
I'm here, Paul.
Yeah, I figured I was over there. Anything else to report, anything new from your end in Dublin?
So one interesting thing, the number of healthcare infected has dramatically gone down. The first week of January, just before we started vaccinating, we had 1,000 workers a week going down with COVID, and it's now down to less than a dozen after the vaccination. So that's been quite successful. One drawback to having the paramedics and EMTs involved in vaccination clinics is the reduction in inter-hospital transfer availability. So we've been limited a little bit with that. We've just had an update on our lockdown. So we're still going to be in lockdown for another couple of weeks, but we've had new quarantine measures introduced. So people coming from a list of, I think it's 30 countries, will have to mandatorily quarantine for 2 weeks in hotels on arrival, even if they have a negative PCR test. If they have a second PCR test during the quarantine, they may be able to shorten that. But that's about it. Things are improving slowly, very slowly.
Okay, good. Hey, I'll stay in touch with you. I may be heading over your way, I think in June, probably maybe right after the Eagles meeting. We'll see. Maybe. We'll see. All right. So good. Hey,
Paul,
yes, go ahead, Jim.
It's
Yes.
Jim. I have another set of questions for Holly from the
Sure.
IFF guys.
That's great. Okay, so Jim Augustine's on. He is usually our link, our liaison to the International Association of Fire Chiefs, and as a result, IAFF as well. So take it away, Dr. Augustine. Okay.
Thank you very much, Paul. Holly, of course, that document, the fire stations are considered somewhere between family and a group home. Somewhere we fit in there. The application of fully vaccinated might also include those that have been infected already or those that have been verified infection with their first vaccine, which knocks a month off. We have questions about whether, 4 vaccinated members, 1 unvaccinated member. So those kind of work setting meshes are very important to people. And of course, we want to be consistent in our application within the stations as we are in the bigger community, still understanding that we have to use universal precautions in the public. But Holly, anytime we can get some of those directions, it'll be really helpful in our industry, and we can provide consistent guidance across IFF, IFC, understanding that any guidance we give is a living document and subject to change as time goes on.
So what something that I might want to bring up is something that Kevin Mackey wrote, because I actually been in fire stations a lot across the state of Florida the last few weeks. And it's very interesting to see what you see as you walk in different stations. Though everybody, when they know you're coming over, may be all masked up, and then you find out later they're not as you come back. And there is that interesting thing. Some places are still requiring it because there's a lot of people, one, that are not taking the vaccine, still refusing to take the vaccine. And 2 is that we do have this issues about the variants being brought along. Plus, we are exposing the public to us as well. So there's the thing. So on the calls, they're wearing them, but in the stations, another thing. Kevin, tell us a little bit what's happening in Sacramento. What are you doing there?
You should have received it.
So I'm sitting here typing a letter right now to the fire chiefs because just since the guidance was released by the CDC, I started getting multiple phone calls and emails say, can we start taking off our masks in the fire station?
Right.
And we have such variability in the firehouse as far as sick calls, overtime, vacations, and things like that. And we've only hit about 58 to 60% vaccine uptake in the fire agencies locally. So that's why I was asking the group. I mean, if I was thinking along the same lines, but the vaccine it prevents transmission potentially, but it doesn't prevent infection. So we know that in the trials that people still got infected with COVID, even though they'd had both doses of the vaccine. And with the variants and the unknowns that are out there, I'm typing this email right now to the fire chiefs that our recommendation is to remain masked in the firehouse until we reach 85% of the workforce, entire workforce that has been vaccinated at this point. And so that's why I was asking the question about what other people were doing. I just want to make sure I'm in the lane. That just seems to make sense to me.
Let me pop over maybe to Ken Shepke, because you got the whole state and you got a handle on what's going on, and maybe Peter, just because of what I've witnessed, which is it's all over the map, you know, that kind of thing. Ken, do you have any thoughts about that or what you would recommend?
Well, I wish, number one, that any of my recommendations would actually be followed when I'm not actually in the station. So that would be the first thing, is let's be realistic about what actually occurs when the chiefs or the medical director are not there. I do think that there's definitely mask fatigue, and I do think that having an incentive for the group to say, hey, you know what, everybody's vaccinated except you, Bob. Why don't you get the vaccine so we can take our masks off? Provides a little extra peer pressure to get that done. So I kind of like that message. From the science standpoint, yeah, I think the variants are a huge wild card. And if you want to be strictly safe, you should do the 85% rule. So I have mixed feelings about it. And right now, we have not changed our mask policy, which is, at least for Palm Beach County Fire Rescue, you're supposed to be wearing a mask while you're in station. But I'm not sure what the compliance is.
And hey, by the way, if Ken, if you don't mind, I'm going to ask you to give a presentation today, if you can, because you've been doing so much work on the long haulers and so on. And if you don't mind, I'd really appreciate you doing that. So, and I think what we'll do is actually, I think we're going to have a follow-up later on with Amal Matu next week on sort of a subgroup of that, mostly the cardiac people, et cetera. So that'd be great. If you could, will you still be available, say, in about 15, 20 minutes until we get through some of the other topics?
Yeah, I'm free. So yeah, and I've got the presentation ready to go.
Excellent. Okay, good. All righty. Let me get back to the next thing. Anybody else want to comment on this or pipe in about this issue about what we're going to recommend for our folks in the stations and so on? Hearing nothing. So Ken, actually, while you're here, will you do me a favor? And there's somebody new on the phone here today. Well, not new, because we've had him present for us before, but going to be a new member now of the Eagles. Okay, we want to welcome him to the Eagles, and you could tell him why he's here to fortify the Eagles. Okay, so if you don't mind.
Sure. So I take it that Jim Roach has joined. We were hoping that he would join today. So I've known Jim for a number of years. He was a chief resident in emergency medicine in his residency class. Brilliant guy who I got to meet a number of years ago. And he came on board our team here in South Florida and started becoming the medical director for Broward Sheriff's Office a number of years ago. And I would love to say that we kind of took him under our wing and showed him how to do stuff. But this guy actually came in and schooled us on how to do performance improvement, quality improvement. And it's just, to my great chagrin, he embarrasses me all the time because he's so much better in most of the things that I'd like to think that I'm at least okay at. So Jim is a brilliant guy. And I think everyone in the South Florida area has really recognized that, whether it's because his institution of blood or his hands-only CPR stuff and no-go with the dispatcher and his improvement in cardiac arrest resuscitation rates, that he's been now asked to be the city of Fort Lauderdale's EMS medical director. So now he has one of the largest, well, actually the largest city in Broward County. So I formally love to welcome him on board as part of the Eagles team. He's richly deserving of that. Welcome aboard, Jim.
Good. Hey,
Thanks,
Jim.
Dr. Shepke. Appreciate it.
Please, hey, Jim, if you don't mind, come on board and say hello to everybody, okay? So.
Oh, awesome. Dr. Pepe, Dr. Shepke, Dr. Antebi. Yeah, it's such an honor to be a part of this group. Just in the past, going to the Eagles conferences and just seeing the different, people from all over the country and all over really internationally. It's really an honor for me. And, being able to be mentored by Dr. Pepe and Shepke and Antebi really was, it's a gift. So I'm grateful for that. And, the things that we've done and that I've seen them do it's really an honor, and I'm just humbled and grateful to be a part of this group. Thank you so much.
Good. Hey, Jim, I have one personal request. Can you assign me to the beach in Fort Lauderdale? Would that be okay?
Yeah, definitely. Station 49. I was there yesterday, and it looks right over the beach. It's awesome.
Yeah, and I think I should help you run the Tortuga Festival too in the future.
Yeah,
Okay,
definitely.
good. All right, fantastic. Well, welcome on board, Jim. I'm glad you're here. So fantastic that you're here. So hey, before I go on, since we're in the kind of the fun mode, Libby, I just want to show you what I've got here in my hands, right? Are you there, Libby Char from Honolulu? So.
Oh, yeah. Oh, that's awesome. Good for you.
Remember, we're going to probably do like the best place to get something to eat, every week segment. we need to have that. But anyways, I got my Leonard's Malasada's coffee cup. Just wanted to make sure everybody else knew what it is. Libby was the one that turned me on to it. There's two opposing things. It's like in Philadelphia where you got the Geno's, et cetera, versus in Philadelphia, but here it's Champions versus Leonard's, and Leonard's I think is a clear winner. So thank you so much, okay, Libby, for being here. Libby, what time is it there, by the way? I'm very curious.
Well, this week it's only 7 right now. Next week daylight savings, and we don't do daylight savings, so I'm gonna have to start working at 5:30 for this Eagles conference.
I know you need an award just for being the Larker of the year. Up at this hour. So thanks for being. Hey, by the way, while I got you on, anything new to report on from Hawaii?
No, we got our first batch of Johnson & Johnson last week, and then we get nothing this week. But we're really excited about that. And we just wish we'd get a little bit more vaccine every week. Okay. Maui's had horrible flooding and rain. One of the dams was breached, and all kind of evacuation and crazy stuff going on Maui right now.
Ah, damn it. That's bad then. Okay. Well, listen, I couldn't resist, that kind of thing, even though it's recorded here. Hey, so have you been officially approved as the health director for the state of Hawaii yet?
So I went through the Senate hearing, but it needs to go to the full Senate for a floor vote.
Okay, got it. Okay, so hopefully that'll happen here pretty soon. We're all behind you and supportive, so that's good. What's the official title? Is it Secretary of Health, or what's it called?
No, it'd be the Director of Health for the state of Hawaii.
Got it. Okay, good. Well, thanks a lot. Eileen, you have your hand up. You want to talk?
Yeah, no, it's great to meet Dr. Char. And I'm just curious if she talked about just getting the J&J vaccine and wanting more vaccine. Is she at all being, I know that the restrictions that Hawaii has done have been phenomenal and that you've done really well. Can you speak a little bit more about your access to vaccine, and is it affected by the fact that you've done such a good job?
Thankfully not. I think they're basing it on population though. So for every million doses federally, we tend to get about 4,000 or 4,400 doses of whatever it is. So we got, I think there were 2.8 million doses of J&J. And so we ended up with 11,900 doses last week. And then I don't think anybody's getting any because they didn't have a big stockpile of it. So we have nothing now. The other thing, we're trying to be really careful to, there's some stigma that it's not as good as the other vaccines just because it was such phenomenal efficacy off of the Pfizer and Moderna. And so we're trying to make sure that we don't perpetuate a stigma of, oh, you're using it in the prison system or in the homeless because it's not as good. When absolutely, it works just fine. It's a great vaccine. I would have no problem taking it. And we're giving it to them because it's easier than trying to schedule a second dose on a homeless guy, to come back for his appointment. So just dealing with things like that.
And no problems with getting syringes and other wherewithal to get the vaccinations accomplished?
So far, so good. The one thing when there were a lot of ice storms across the mainland, we got absolutely nothing that week. And then Pfizer managed to ship a little bit late, but the Moderna was completely held up for over a week.
Thank you.
Well, let me move over real quickly. Before I forget, talking about surveys, let's knock out a couple of things really quickly. One of the things we were going to probably do is send you all a first survey to see who is going to be seriously interested in coming to our meeting here in Hollywood, Florida, in the land of Jim Roach and Randy Katz and Peter Antevy, et cetera. at the Hard Rock on that Flag Day week, June 14th, the week of June 14th. I don't know if we have a pretty good commitment for everybody coming down. We're going to abide by whatever the hotel tells us to do, or whatever whatever's going on at that moment in time. But whether we have to still have distancing, we're going to set up as if we have to be distanced and as if we have to wear a mask. But most of us will be vaccinated, and I think that most of us are going to be coming down here, and maybe even I think people are planning to take along loved ones as well, so they could go do some vacationing either before or after, or take the kids to Orlando, or go down to Key West, or just hang out here, or take a cruise. So, but we're going to probably send up a survey to everybody just to see, do you feel pretty confident or relatively confident, that you're going to be able to come, etc. So anything else to add to that, Scott Gilmore, because you're the person that's liaisoning with us with the Fire Chiefs Association down here.
Nope, that's the main thing, Paul, was getting that survey out.
Okay, good. All righty, well, fantastic. Then, and we'll just remind me, let's get it done this week. Before I forget, I'm looking at Rob Dunn's name, and Rob, we want you to know that there's someone got on the phone from the mayor's office in Detroit last week and was bad mouthing you really heavy. I don't know what that was about. Can you explain that? No,
yeah,
Sarika,
she's the best. She just tells it like it is, man. So she's got to bad mouth me. No, she's awesome. She's our Harvard fellow. Government fellow who's working for the city this year, and what a perfect year to work for the city because we found a lot for her to do.
Yeah, and it's really helpful and information get for the CDC to see all the stuff you've been doing to help with underprivileged and underserved populations, etc. So you guys have done just a great job up there. And then and I got to tell her about how she needs to get me a job. She was really grateful to be on the Eagles call, so I said, well, just send me a case of Sanders hot fudge, which, by the way, I did get. Okay, I just want you to know we got to had to give a pitch for the food coming from Detroit. It's great stuff. So thanks a lot, Rob. Anything to report from Detroit before I go on to our other topics?
Well, a lot of people probably saw the little kerfluffle. Generally when some of our governmental leaders go off half cocked, they've kind of done the right thing. They had to kind of walk back a little bit on the J&J, kind of like what Libby was talking about some of the perceptions, and some of our officials were kind of not listening to experts by their own choice, and initially were like very hesitant about the Johnson & Johnson. They have since gotten over that. We are getting a bunch of Johnson & Johnson and have a good plan to use it. But it's interesting. One of the things that really I think helped counteract what our politicos were hearing was the fact that our own surveys of people within our employee group and essential workers is we have a lot of people that were just waiting for a one-shot vaccine.
Yeah.
Like, people that are perfectly sensible people, but said, I'm just going to wait and get the one-shot one, including, our superintendent of EMS and some other people that had just chosen not to get the initial rollout of the vaccine. So I think that helped them understand that it's, it's a good vaccine, but some people really want it. And that if we really want to address some of these, some of the hesitancy, we've got to be able to offer people what they want.
Yeah. So Holly, that's a good one to take back to add to our list of things that we've provided for you about the hesitancy issues. Okay. So, or I should say not hesitancy issues, but not going to do it issues, right? Really. Right. So I'll tell you.
Hey, Paul, I have to tell you, we're seeing similar things. We even have certain populations that have been waiting for J&J because they feel like it's a household name. They feel more safe with it. Now, obviously, if you look at it from a purely scientific standpoint, you might get a different opinion. But we definitely have populations that have been waiting, not only either side effect profile, single shot, but also the household name of Johnson & Johnson. So I think some of those concerns were a little unfounded.
Interesting stuff then. Okay, good. So I want to get through a couple things. One thing I just want to tell you about, since we're on the subject of the N95 survey, I just want to get that one out of the way. We've got a bunch of more cities, but there's nothing different than what you saw before, Holly, if you saw it, or what Sue Visser got to see before. Just wanted to give you a follow-up on that. I just reviewed it myself and I got our last results, and nothing's changed. About 80% of the people are using them either for a single patient or just for one day, and that's basically it so far. All right, let's see. Hey, Amal, you had a quickie that you wanted to talk to us about, right? If you don't mind. Amal Mattu.
Yeah, sure.
Amal's our professor. What did I call this? Oh, this is for, what did I call this one? I don't even know what I said here. So, but anyways, the latest
Comic relief.
Raven Haven from Raven Maven. That's it. So
Yeah,
welcome on board.
There's been a recent bolus of articles talking about athletes with prior COVID infection and some updates that I'll present next week. I want to put all these articles together,
Yeah,
but
good.
just as a real quick thing, there was something published actually just today that I threw together, and I'm just going to share some slides real quick about this interesting article. So I posed this question: where are the best cardiac arrest survival rates in the United States? And most people would probably say it's Seattle or something like that. It turns out it's actually in Hollywood. So article that was published again just today, looking at TV medical dramas and the rates of resuscitation. Many of you probably know what this is going to end up resulting in. And this is a bit of a follow-up from a famous study that many of you know about from 1996, where a bunch of authors sat on couches and watched 97 episodes of ER, Chicago Hope and Rescue 911. And amongst these CPR episodes on TV, 77% survived short-term, 67% survived long-term. And this is a bit tongue-in-cheek, but it's actually very important because the patients that we take care of get a lot of their information about survival rates and their expectations about survival from TV. In this particular study, this is a very recent study. They looked at 836 episodes, 216 CPR attempts, and they looked at whether proper compression depth was followed, and that only occurred in about 32%. Paramedics were the best amongst the different healthcare providers that were shown. And then survival rates on average were about 62%. And the reason why I think this is important is because if we go back a handful of years, there was this article published in Academic Emergency Medicine where they surveyed lay people and they asked them, where do you learn about CPR and survival rates? And a lot of people, not surprisingly, said that they learn about CPR from watching TV. And amongst the people that learn about CPR and TV, those people estimate generally a 70% survival rate when their loved one shows up in the emergency department. And for those of us in the ED, it's not surprising. And I'm often shocked at how often you talk to your patient about their loved one who's passed, and they're shocked that their loved one was getting CPR at home, and they assume that because they got to the hospital, they're going to survive. And it's just very shocking to them. Also surprising in that study that they did back in 2000 was that amongst people that had some degree of medical training, and this includes nurses, techs, not so much acute care physicians or paramedics, but non-emergency medicine physicians, those people also have a bizarre estimate on survival rates, a 74% average predicted survival rate amongst people that are not involved in acute care medicine. And there was a survey of fourth-year graduating medical students, and those medical students predicted a 42% survival from CPR. So bottom line is we've got a long way to go in terms of trying to educate the public and also our own people in healthcare about the survival rates. And I think this largely accounts for why there's this disparity in terms of what we expect versus what the public's expectations are when these patients show up in the emergency department in active cardiac arrest. So I think it would lead to a really great follow-up study, just surveying the lay public. And I think, unfortunately, we'll find that even after 25 years, TV is still very misleading in terms of educating the public about what people's survival rate is going to be.
Right. Well, good. Yeah, it's a great one. Actually, we do need to get onto that. So that's it. That's a good.
Hey, Amal.
Yeah.
Just a point of clarification, because with this group, when you say Hollywood, we got Peter Antevy, we got Ken Shepke, we got a lot of people that think Hollywood, Florida is the only Hollywood that is out there. But I suspect you may have meant a different Hollywoods. I just want to clarify that.
Yeah, it is Hollywood, California. I'm not sure about Hollywood. And also for you, Chris.
Whoa. I mean places exist outside of Florida? Oh, this is news.
Well, I tell you what.
You can say California. You can say that again. California. This is what we're talking about here.
Wait, Chris and Amal. How about we say the Hollywood that's currently open? How's that? Okay, thank you very much.
There you go. And Chris, they didn't look at people's. They did not look at how often patients in breast receive droperidol, just for your own purposes. All right.
Yet another flaw in the study.
All right, so listen, so we can get through today. What I'm going to do is, since we are picking on Ken a little bit today, we'll go ahead and have him do his thing about long haulers. And then after we do that, we'll move on to a presentation on the respirators that AJ was going to be doing for us. And then hopefully we'll still be able to get it in. If we can't do it this time, we'll get Remley and Paul Banerjee to talk about a new program they have for stroke screening. So with that, haul away, okay?
All right, can you see my screen there, Paul?
Yes, I can see.
All right, great. So there's a little resource there for you guys, folks. I'll just leave up on screen for a second. This Long COVID Alliance. It's kind of a patient-centered research area where they're kind of putting together their own stuff because of lack of medical community focusing on this. So COVID long haulers, I initially spoke about this way back in the spring. We started seeing this phenomenon of folks who were getting COVID and they weren't getting better. And so here are some of the symptoms, patterns that we're seeing. An Italian study, fatigue, shortness of breath, joint pain, and chest pain. And this chest pain has been particularly concerning because folks have all sorts of cardiac workups, and we don't really know what's causing this. So there's another group here in the U.S. It's actually international now. They had 14,000 members last count. 91. They did a survey of their folks with 640 respondents, and these are the symptoms they reported beyond the 40-day mark. And again, fatigue, chills, sweats, muscle aches, headache, brain fog, and GI issues. So it looks like this fatigue, aches, and neurological stuff seems to be a common thing with these folks. Shortness of breath, chest pain too.
Let me interrupt you for a second. When you say GI stuff, is it more on the diarrhea side? Or
yeah, you know what? And I'm not sure that really fits what I'm going to get into here. We do know that COVID infects the GI tract and can infect it for a longer period of time, which is why some municipalities are actually testing the stool for COVID to get an idea of what the community burden is of COVID. So I suspect that's actual still ongoing infection rather than true long hauler where I believe the infection's gone and there's something else going on.
Okay.
So I do think though, when you look, one of the problems when you look at this is that these are multiple processes and diseases, which is confounding folks when they try to help this. Maybe they're sick because of loss of conditioning. They were sick for a while, so they're in bed. We do know that happens with elderly folks that hospitalized for a little while and they lose a lot of proximal muscle strength. Could be a post-viral reactive airway disease, which we've seen with other viruses. Could be actual organ damage, like with lung fibrosis or viral myocarditis. But this last one I'm really going to talk about, which is sort of this catch-all thing that's just been around for a number of years, myalgic encephalomyelitis chronic fatigue syndrome. 75% of cases of this ME/CFS began with an infection. Even prior to COVID, there was the Epstein-Barr virus was the major culprit, but lots of viruses have been leading to this thing. And I think really that there's a number of triggers that leads to the same pathophysiological event going on is my guess. So there's some other stuff out there that also could fall into this catch bag. Autonomic dysregulation. We've all heard of POTS, right? Postural orthostatic tachycardia syndrome. One of the symptoms of that is actually brain fog. Sounds a little similar to what these COVID long haulers are talking about. So I think autonomic dysregulation may be part of actually this post-COVID symptom and may be part of other post-viral symptoms. Now, another theory out there is that the virus isn't actually cleared, that they still have a reservoir virus either in the testicles or the ovaries or other tissue where your immune system doesn't typically get into, and you're getting these bursts of virus leak out there, and that may be why you're having some cyclical stuff. But I think these last two make the most sense to me, which is an aberrant immune response or possibly mitochondrial dysfunction. So that's what I want to talk about. So post-exertional malaise is definitely one of the hallmark symptoms of ME/CFS, and I think these post-COVID folks are going to fall into ME/CFS, meaning they exert themselves and then they pay for that afterwards. And it's estimated that 10 or 25% of folks with COVID-19 become long haulers. That means that translates to millions of people, millions of patients. This is going to be the next public health crisis because many of these folks are not able to work. In fact, just going from bed to taking a shower, going to the bathroom, for some of these folks with the most severe symptoms, that's all they can do. So it's really pretty severe thing. Now, how do you test for this? There's a problem that we can't test for it, but you can do a test for mitochondrial damage-induced disease, something called a bioenergetic health index, which really, it checks mitochondrial function. That's one thing you might see. And there was another study that showed that certain cytokines are actually markers in ME/CFS. And I truly believe these COVID long haulers are going to wind up in this bucket of ME/CFS. And when they did a study of ME/CFS patients, they found that certain cytokines were higher and certain ones were lower. And this may actually be the lab test of the future, is looking at these cytokines or one of those mitochondrial tests. So just to go over the basics, a very simple slide I'm going to put up. I'm sure you guys all remember this perfectly well from medical school and biochemistry, is the citric acid cycle and the electron transport chain. Now, just to make things simple, the whole purpose of this thing is basically to convert chemistry into electricity to convert to ATP. That's really all this is. So just like you have a zinc copper battery that has electrons flow, that's all the Krebs cycle and the electron transport chain in mitochondria is. It's just a flow of electrons from one chemical molecule all the way down to ATP. So the key things in that, if you look at this, you've got this thing called CoQ10. CoQ10 is called ubiquinone because it's ubiquitous in life. So anything that's a eukaryotic cell has CoQ10 in the mitochondria to produce the electron transport chain. So it's part of the wire that the electrons in this chemical reaction, the electrons travel down this electron transport chain with finally it charges your ADP to ATP, which is your battery store of energy in the cell. And statins decrease the body's ability to produce CoQ10. One of the symptoms of statins is muscle pain and weakness. Sounds a little familiar, right, to these chronic fatigue folks. Reactive oxygen species is a side effect of a dysfunctioning mitochondria, meaning if these electrons don't go all the way down the chain and then charge ADP to ATP, they end up being released as oxygen-free radicals or reactive oxygen species. Reactive oxygen species then cause damage to mitochondria cell structures, which causes inflammation. Inflammation causes reactive oxygen species, and you start getting this cycle of dysfunctioning mitochondria and chronic inflammation, which affects your cytokine. So again, it's a chicken and egg type thing. I do believe this is a chronic low-level inflammation and mitochondrial dysfunction thing going on. So here are some theoretical, based on biochemical principles, treatments for this, assuming that this theory is correct. And these are all generally harmless things. CoQ10 supplements have been tried for statin folks for a long time. The problem is CoQ10 is a very lipid molecule. It is very, very poor bioavailability, but some bright person just came up with something called MitoQ, which is basically CoQ10 attached to a positively charged molecule, and mitochondria are negatively charged. So you get 500 to 1,000 times bioavailability to the mitochondria with this particular formulation of CoQ10. And that fixes the wire that is being damaged so that the electrons can transport down, because CoQ10 is part of the electron transport chain. N-acetylcysteine is a oxygen-free radical scavenger, and we know from acetaminophen overdose, it regenerates your normal intracellular oxygen-free radical scavenger, which is glutathione. So N-acetylcysteine, another harmless medicine. We use it for COPD folks because of its pulmonary function. And then the last one is mitochondria food. And there's a bunch of different things you can look at this. Is nicotinamide mononucleotide and a couple of other ones, but D-ribose is really the key ingredient. So when you look at ATP, NAD, FAD, all these different things that were in that complex thing I told you, they all contain ribose. It's not something you get in food. It's something that your body makes. But if your body is not producing good energy, it doesn't produce good substrates. So you can actually supplement that. There's actually one study that was done on chronic fatigue folks where they gave 5 grams 3 times a day of ribose, of D-ribose to folks, and they had 2/3 of their patients with chronic fatigue syndrome actually got better on that. So those are basically the theories. I'll turn it back over to you, Paul.
Yeah, so what worries me the most about what you're talking about here is that you probably actually understand that slide that you showed us, okay? You know, the slide number 8 of yours, okay?
The simple one? Yes.
Yeah. I want you to know that it had flashbacks for a lot of our audience back to the days of us doing this in medical school and even in college. It was just amazing. So What are those? What was those H plus things? That's what I wasn't sure about. Okay, so
Yeah, so it's all about electron and proton gradients. That's all it's all about.
Yeah. Well, I'll tell you what, there's something very interesting here because I've learned a lot about this stuff over the years, especially with issues about using estrogen as an anti-cytokine thing. And so it's kind of interesting. It kind of fits all that. So that's kind of neat. So the one thing you'd have to, there are various other symptoms that have resulted from your slides, such as John Jew getting vertigo to his, you know what? And so, you know, there's various things. John, are things spinning out of control for you? So.
Yeah, it's like flashbacks as well. So I can't believe you just did that.
Hey, though, but John, is there any commentary that you have for that?
Yeah, I think Ken's really on the right thing. If you actually look at it, the symptoms of brain fog versus anosmia versus fatigue may all be different. There was also difference between MIS in children and MIS in adults, and it's the cytokine between the Th1 and Th2 balance, as Ken, I think, was bullet number 4. So I think it's a abnormality in cytokines, in addition to autoimmune possibilities in the brain, as well as the mitochondrial thesis as well. Those are my 3 leading causes.
Well, I didn't mention on the presentation, when you look at mitochondrial disease, you start seeing, like, people with genetic mitochondrial disease, before they really deteriorate and they ultimately die from that kind of a thing. But early on, they get exactly these same symptoms: muscle aches, muscle fatigue, brain fog. So I do think energy production is part of it, and definitely inflammation is part of it. And one causes the other. It's a feedback loop between the two.
Okay, so I think at this point in time, we can probably move on to the next subject. Anybody have any questions for him or any other comments about the presentation? If not, okay. Oh, wait, we'll get to see what Professor, I got to see what this note is from Professor Matu. That was great, Ken. I don't understand any of your slides that had pathways and arrows, but the rest of it was quite helpful. Seriously. So that's good.
Paul?
Yeah. Yeah, Peter, go ahead.
Paul, this is Peter. Yeah, so Ken was nice enough to share that information with me a few weeks ago, and I just sent out a Dropbox link, and I've sent that regimen out to every long hauler I know, and it's all been great reviews so far. So thanks, Ken, for providing that information. And I have the Amazon links in the document. They're expensive, just FYI.
Yeah, well, I would tell you that the D-ribose, so some of the more expensive ones that I gave you, the D-ribose is the subunit molecule that produces all the other more expensive ones. So now you have a cheaper alternative to the other things that I gave you.
All right. Well, listen, anybody else have any comments to make before we move on? But that was great, and thanks a lot. You may have to repeat it for us again someday, but whatever, as we get older. So let's go on then. In AJ, you've been very patient with me. You want to go on and talk a little bit about the project you were working on? I think I called it take a quick breather, but safely, right? So
yes.
Talk about the new project, and then maybe Peter, you can. You're aware of some of this too, so you can maybe pipe in as well, Dr. Antebi, okay? But go ahead.
Can you hear me? Can you hear me?
Yes, very well, yes.
Okay. Well, gentlemen, once I heard that Dr. Antebi was involved and saw this device, I wanted to bring it to you. Now, after seeing Ken's slides, it's all the more important because the special filters built into this aerosol mask can filter out all of those slides and all of the bubbles that were on there. Aerosoless of South Florida recently released this. It's called a safety neb. It's kind of revolutionary. It's a new aerosol delivery device fitted with water-resistant filters over its vent holes and sponges at the nose and the chin level. And that's to protect filtering of any exhaled breath or cough. It lets exhaled CO2 out, but keeps the pathogens inside the mask. Dr. Paul Lewis, who's been in South Florida and now is a board certified EMS physician in Salinas Valley, California, really shows that the secret is behind the seal of the mask. It has a built-in, what do they call it? Faceplate right here that when it goes on your face, helps secure it like a CPAP mask. And then you bring the strap over And there's an ingenious, you can not only tighten the strap, but if you could see it here, there's a little hook that you can lock it into. Very simplistic, very accurate. Dr. Antevi and Dr. Steve Rios found that, regular oxygen masks allowed a significant amount of particulate matter to come out into the environment or confined space of an ambulance. The safety neb produced the release of negligible particulate matter. They all stress that this is an adjunct to other PPE, but the comparison between the two can be seen on a link that I send to you. And its cost is around $10 a piece. And rescue inhalers that they're using in hospitals right now are about 100. What's really neat is it comes packaged with this attached to it that tells the providers that these are nasal pads, don't remove them. It comes with directions that can be stuck on. They're on a double stick. And it also comes with a diagram. So I think it's a really cool little device that you should look at. I gave you the physician's name on there to follow up with, but Boundtree and others are going to be carrying it. And I know that in San Antonio, Dr. Miramontes is using something very similar in his hospital, but the nice thing is that hospitals will like the price of this. Good price point. That's it.
Good, thanks a lot. So Peter, do you want to comment on that at all?
Yeah, thanks, Paul. Thanks, AJ. Yeah, so this is something that on our Florida webinar came to us a few months ago. And, before I instituted it in my services, I wanted to study it. And that's why I was fortunate to have Stephen, who's trying to get a residency. He came to my agency and he basically, spent the weekends doing this. And it was pretty dramatic, enough that it convinced us and it convinced my chiefs to implement it. And the feedback's been great. And so it's just something that we're trying to get back to life as usual again. And I think the nebulizers were a big one. And instead of using kind of the old school drugs, we can get back to what we were doing. So appreciate the time here. Thanks.
Okay, good. So then you'll give us some follow-up on your experiences then. I mean, you're saying it's been good feedback, but I just want to know, are there anything else you're doing in terms of, are you just going to presume then, are you doing any further studies is all I'm getting at? I guess you're doing follow-up on patients and cases and all that kind of thing, correct? So
yeah,
in terms of, what else are you doing in terms of quality assurance for this?
Yeah, that's a great question. I mean, really, we are following which people at our agencies are getting sick, if any. And on every case, we use ESO. We have a little button there that you just push if it's a PUI, and we mainly do that for insurance reasons, right? So that we can get workers' comp. But we're able to kind of go back, and anyone who gets sick, we're able to go back and see what patients they did treat. And so we do have a chain, so we can go back and see, did you treat a patient when you were using this nebulizer? So we haven't had that many uses. Obviously, we just started using it after the research study completed, but we do have a way of looking back, Paul, and we plan on doing that.
Okay. So one more thing, I guess, David Miramontes, do you want to make a comment about the system you're using?
So this is not something we've deployed yet, but interesting. I had a pulmonary function test in the hospital, and they handed me this gizmo, and they said, "Well, here you need to do an albuterol treatment." I said, "What the hell is this?" She goes, "Oh, it's a closed neb system that we're using in the hospital now." And so I put the link in the chat. So it's a handheld device, unlike the one that AJ showed. So it has a filter going in, and it has a one-way valve going in. So if you suck and it's beyond the capability of the aerosol, it drains room air in one way. And then when you exhale, that valve shuts and it goes out through the filter. So I like this mask idea because it's totally contained. With the nebulizer system that I put in the chat, if they take it out, well, then they're breathing out without any particles. So I'd like to try this one that AJ just showed and that Peter's using, but please give us an update, especially if you have, air particle production, et cetera, from the mask versus this. They're about the same price, both about $12.
Okay.
Yeah, just Paul, just one more item. Sorry, that if you go straight to the manufacturer, you can get it for cheaper, like 8 something is what we do. We don't go through. Sorry if there's any people on here that the Boundtree people, but we go straight to the manufacturer.
All righty. So anybody have any questions or anything else to put into that? We look forward to it otherwise, to seeing what you find out and what your experience has been. And with that, let me now push over to the Espanol version of our meeting today, right? So speaking of which, many people may not know this, but Dr. Remley Crowe, besides just being this like brilliant person, well, used to be a paramedic years ago in Mexico for almost 5 years, which is just extraordinary. And as a result, speaks fluent Spanish, has come up some very cool things. She and Paul Banerjee have come up with a new, let's say, algorithm is a good way, a screening tool. So if you don't mind, Paul and Remley, take it away. I don't know who's going on first.
I think Remley.
I'll tee up a little presentation here. Y'all seeing the slides?
Everyone see it? So basically what we're looked at is in our county, we have 30% of our population is Hispanic. And we were trying to get a better feeling at how we can respond directly with this kind of people. And if you looked at the stroke disparities, that Hispanic Americans have strokes at a much younger age, experience much worse outcomes, and fewer than one in 5, so less than 20% could actually recognize 3 signs of a stroke. And in this community, hemorrhagic stroke is far more prevalent than other communities. So we looked at finding ways to help recognize this in the community. Currently, right now, there was FAST, which has kind of progressed to BFAST, which we're using in our communities, but there was no significant correlative algorithm that we could use in the Spanish community to help them recognize stroke.
Right. And so what we saw was there's no Spanish mnemonic that meets those ideal characteristics, especially for public recognition like FAST or BFAST. There are translations directly from the FAST and BFAST, but that won't resonate with the same memory aid as it would, if there were a Spanish mnemonic.
So the 3 amigos is Marcelo Wilson's the kind of the core person behind this. We met at the first Florida Stroke Symposium about 2014. We've kind of kept in touch. We were working on finding a mnemonic that worked for the Spanish population. We initially came up with Rapido. It wasn't kind of going where we wanted it to. So I invited Remley to join us, and she kind of revolutionized and changed our whole thinking and made it actually fit.
And so here's a draft of what we've come up with so far, and this is of course freely available. We came up with the mnemonic ahora, which in Spanish means now. And so each of these is a part of the BFAST. So the A stands for andar, which is walking or balance. And then we have hablar, which is the speech, ojos, eyes, face and head. And we added the does the patient have a terrible headache unlike any previous headache, because this has been kind of phased out of a lot of the English tools, but it is directed at identifying some of those hemorrhagic shocks, which we saw is a little bit more common in this population. So we felt it was important to include. And then finally, any weakness in arms and legs. And then of course, to call 911, even if the symptoms seem to resolve. And so Paul will talk a little bit about how he's pushed this out in Florida a little bit.
So what we did is we partnered with our community, and Viva Polk is a local Spanish newspaper that's founded by a lot of our hospitals, and we presented this actually in the magazine, and it's got over 40,000 subscriptions. So it's been widely distributed in our county. And what we've also done is partnered up with our two of our 3 major hospitals here. Advent Health, which is like the 3rd largest hospital system in the country. Bake's 15 hospitals in the West Central Florida area. It's been part of our protocol implementation. So we have a laminated form that we take into houses that maybe don't understand what BFAST is, and they are just checkbox with the people, and then they can screen them more effectively. We're going to start school education. Hopefully the children will be able to educate the parents. And we've been asking for money, and the hospitals have been great in providing that for like magnets we can put on in the houses and any kind of information we would need.
Okay. Well, thank you very much. Can you translate the What was that? The last thing you had on there? I can't remember.
Oh,
Sorry.
preguntas, any questions?
Yeah. Oh, okay, good. Any questions? Hey, so this was a stroke of what, El Genio? Is that how you say it? Right?
A stroke of genio, sure.
Yeah. Okay, stroke of genius. That sounds good. Thank you so much then for the translation. I really appreciate that. I always still am grateful to you even translating into Italian that last time. So, all right, anybody have any questions for them or thoughts or anything else you want to hear about?
That was fantastic. I'm going to be R&Ding that for the Florida Department of Health. So just some of your stuff, Paul. So that's great stuff. You and Remley, a fantastic job.
Thank you.
Yeah, Paul, can we get that sent out? Because in my land, that's perfect. I would like to get this with our dispatchers.
That's what we're doing as well with our dispatch as well.
Yeah, I was
Happy
going
to
to say
share
the same thing. I would love to have that.
Jim, I'll just send it to you and you can send it to everybody.
That's a good plan. I like that.
Or you can send it to me, Paul.
Yeah, that's what they were asking. They were asking if we can send it to you. And I said, yep, I think that's a great idea. Send it out to everybody. So, all righty, that's good. Who are all these people walking around your house, Jim? Is that your bosses there?
It's the boss. Yes.
Yeah. That's great. Okay, good. Well, thanks a lot. I'm trying to think. There was someone I was going to ask about this. Well, I guess, I mean, that's it for now. So, all right, sounds like a good plan. Anybody else have any questions or answers, or sounds like this is a good thing for everybody to see. All right. Hey, before I shut off the call, I do want to slip back to John Kramer. John, how are things percolating with you guys in terms of this issue about the mass in EMS stations, whether it's, you know, fire stations or where else? Any thoughts? Are you guys working on it, or you want to wait till the future to talk to us about this?
You talk about the N95s?
No, I'm talking about the vaccinations and not wearing masks in the stations and things like that. That's all.
I'm sorry. Yeah. It was interesting. I had a call with rep from the CDC earlier this morning, and it's sort of, it supports the comments that Holly was alerting to earlier. They are hoping to get out relatively soon, but they don't have a timeline for similar guidance for healthcare workers, followed then specifically for the EMS environment. So those are things that are in the works, hopefully soon, but we don't have a specific timeline.
Okay, fantastic then. Thank you so much. Let's see, a couple of people I do want to, Tom, has this been interesting for you so far, Tom Hurst?
Yes, it has. It's been really interesting to get the US perspective and the wider EMS system perspective. So thank you very much. Thanks for having me.
And I'm just kind of curious because you guys are in a tight space sometimes in the helicopters, right? What are you doing there? Anything in particular, or anything we need to know about, or you know, or is it, you know, are you using just the usual equipment?
Yeah, we're using the standard equipment on the way out. In our area, the flight times are short, so it's not a massive challenge. Decontamination of the aircraft has been, after aeromedical transfer, either of all patients or patients with COVID, has been a problem. And nationally, that's grounded some aircraft and provided some air operators with big challenges about keeping flying. And we've had to isolate the cockpit from the sort of patient cabin, because obviously the pilots can't fly in the sort of respirators that provide adequate protection because it interferes with aviation safety and their comms. So it's given us a few headaches over the early parts of 2020, but we got over those and we're sort of just adjusted to it, I think, now.
Okay, fantastic. Just interesting stuff. Hey, I was just thinking while we're kind of have a little bit of time here, Ben Launer, we hadn't got to talk to you much about Baltimore, but Ben, you even knew where Station 49 was. Aren't you from this area originally?
Yeah, we go way back from Nova Southeastern, the Harvard of the South, but not in not in Hollywood. It's Davie.
I thought Harvard was the northeastern of the north.
I got my EMT and paramedic in Florida, so shout out to all my Florida colleagues.
Okay,
Broward Community College.
Oh, really? Who's the medical director there now? I think they've gone downhill.
Well, I like to bring up the rear, Paul, but
yeah. Okay. Peter is the medical director. They're a great group. We've had them on, actually giving us some really good information. So that's been good. All righty. Well, thanks a lot. Anything happening in Baltimore we should know about while I got you on?
So this conversation about COVID briefly, we mentioned this before, is really, I think, motivated BCFD to really embrace alternative transport and alternative destinations. So I've had some offline conversations with members of the group And we're really starting to expand our ability to connect with local telehealth hubs and transport people to urgent care stabilization centers. The most, I think, daunting task of this is trying to do medically informed dispatch, which has been going on across the pond for quite some time. So I
Yes.
look forward to I look forward to updating the group on that. But this has been, obviously this is a pre-COVID need, but I think finally it's shed some visibility on the need to really dispatch and respond to things other than emergencies.
Yeah. Okay, good. All right.
Thank you.
Let's see. No, thank you for being here and being on board with us. One person I wanted to hear from is Emily. Emily, how's this been so far for you guys in New Orleans, and what's latest there?
So generally speaking, as far as, I'm sorry, are you speaking about the vaccination?
Oh, anything. I just want to know what your status is, what's the current problems you're dealing with, et cetera. And post Mardi Gras, did you have any kind of, like, let's say, increases in cases that you're aware of?
Great question. Well, we kind of lucked out with Mardi Gras, and that Mother Nature helped keep the crowds quite slim. We were in freezing temperatures, which doesn't usually coincide with Mardi Gras. So everyone really stayed indoors. And so we didn't see any COVID spikes around that. So we were pretty fortunate in that regard. Now we're shifting really into support for the vaccinations, which, I think as everybody has already expressed, is really exciting, but simultaneously challenging managing the resources to do that, as well as the 911 response. But, given that I think today was exactly 1 year, or yesterday was 1 year from our first case, we're as stable as one can be in the midst of a pandemic. So
Yeah.
thanks.
Okay. Well, thanks. And thanks for being here with us. Really appreciate it.
Yeah, I've enjoyed it. Thank you.
Okay, good. Anybody else? We got a couple of minutes left, but I just open it up to anybody who wants to pop in, RJ or Terry or any of the folks that are out there still, Mark, anybody want to say anything? Jeff, Joe Holly, Jeff?
Hey, Paul. Andy with a quick question.
Yes, go ahead, Andy.
Hey, guys. Good afternoon. Question came up with some of the folks I work with looking at a new product and wondering if any of you guys are using a standardized process to evaluate proposed new equipment in EMS. And full disclosure, the item I'm talking about is the SAM Thoracite, which is this little yellow thing that goes in your armpit, which is supposed to help improve where you would do a needle decompression or a chest tube. Personally, I find it a little confusing to use. I think it's something that would be good to see some data on. But I just wondered if there's any structure or process out there that your departments use when you're taking on a new piece of something. And if there was, I thought I would ask to see if I could get a share of it to get your best practices.
Okay, anybody want to jump in on that one?
Hey, Dr. Garrett, it's Jeff Hayes at Austin. If you want to contact me offline, I'll be happy to talk it over with you and send you what we have.
That'd be great. Thanks, Jeff.
Anybody else?
Hey, Paul, it's Glenn. How are you?
Good, Glenn. Go ahead.
Yeah, can I just ask, about the Ebola variant of COVID now that's going on, as we're one of the 6 airports? Just want to know from our European colleagues, what kind of screening they might be doing.
Okay, Nick or Tom, any screening you're doing for Ebola, or are you aware of what we're hearing?
I don't have any information, I'm afraid. It's far away from my area of work.
Yeah, sorry to put you on the spot. How about you, Mick?
Nothing for Ebola, no, but they're going to start screening in the airport when the quarantine starts in about a week.
Okay, got it.
Thank
All
you.
right. Sorry, I don't know if there's anybody else. How about that other, what's the other overseas place, Honolulu, anything out there? Usually you guys are a big target. Okay, but then again, Dallas wasn't, and that's where the first case was back in whatever that year was, 2016, I think, when we got hit with it. All right. Okay, let's see. Anybody else have anything they'd like to say before I shut everything down for the day?
Yeah, Paul, this is Terry.
Yes, Terry.
I'd like to know from our Texas folks whether they're anticipating a big surge in about 4 weeks.
And is that because of the opening everything up on Monday or whenever it was supposed to be yesterday, I guess? Is that what it happened?
Precisely. Yeah, exactly that.
Yeah, surprisingly, most of the businesses are not going to drop the mask mandate, like our grocery stores, HEB, Whole Foods, Target. They're so in Texas, as a business owner, you're allowed to dictate hygiene practices and mask wearing. So many of the businesses, schools, et cetera, are continuing the mask mandate regardless. And actually here in San Antonio, our district attorney and the police department said, look, you tell someone to wear a mask and they don't want to wear it, tell them to leave. If they don't leave, we'll come arrest them. So we're actually, our area is kind of trying to circumvent the process, so to speak. So we can't legally do a local or county mask mandate, but businesses can require on their property what they want done as far as protocol for COVID. So we're kind of doing an end run around it. So the governor just released the legal requirements and penalties, but businesses can still enforce a mask mandate. And we are doing so in the fire department, the hospitals, the city, all that stuff. So fortunately, a lot of this might be a little bit of stuff about nothing because people are going to continue to wear masks.
Okay, got it. Anybody else have anything to add to it? Well, we will be following it. I'll tell you that. We'll be following some other places around the country as well. One thing I was thinking about asking about myself was trying to remember who it was. I'm looking through the list of people on here that I wanted to ask about. I think it was Angus about Super Bowl. Anything come of that, or are we past that now? And were there any spikes?
Yeah, the best data I saw locally was that there were a small number of cases officially associated with the events. There were maybe some larger number of cases from informal, not officially sanctioned events. But the overall conclusion here locally is that it was not a super spreader event.
Okay, yeah. All righty. Well, I think people are just in not necessarily behaving perfectly, especially a lot of the younger people or whatever it may be, but or others. And but the bottom line is that overall, in general, we are behaving a little bit more, and people are at least more conscious about that. So, and it's still striking how much we didn't get flus, or we didn't get other colds or other kind of things that we usually get throughout the year. There's been a silver lining in all this. So, all right. Well, anything else? If not, I'm going to probably say welcome back, my friends, of the show that never ends next Tuesday, which I'll probably be doing once again from one of my airport hotel restaurants. As I get ready to come back here, I'm going to head off this afternoon back to Dallas to pick up the pieces, etc. So that's it for me. Okay, and thanks a lot. And then welcome Jim Roach again to our little Boys and Girls Club, and really appreciate you being on board with us. So we'll see you later. Okay.
Thanks, Paul. Take care, everybody.
All right. Yeah. Okay. Bye-bye.
Thanks, Paul.
You're welcome. Thank you.
Thanks, Paul.
Hey, good job today, everybody. Jillian, great job today. Okay. Really appreciate it.
Yes, sir. I'm actually calling in from El Paso.
Say again, are you? Okay, cool.
Yeah.
Good.
Be here for a few weeks.
You have family out there, or what are you doing now?
It looks like I'm going to be coordinating a vaccination of all the school districts within this region, which is 57 school districts.